going to be talking about treatment considerations of biomechanics and fixed prosthodontics. And one thing that's so remarkable about dentistry is that for each situation, you can have multiple treatment plans. And when I handled this course for the third year, so it's never too early to start wrapping your head around what type of treatment your patient may require. And when we talk about treatment considerations, you first have to make a diagnosis. Each problem that you list will have one diagnosis. You can't have two, you have one. And the treatment plan is formulated off that diagnosis. So when we start thinking about treatment, we want to remove disease. It could be periodontal disease, it could be caries. We want to then think about how to rehabilitate this patient, how to restore the teeth, how to replace the missing teeth. And then finally, the maintenance. What does that patient require in order to keep their dentition healthy? Well, first and foremost, they have to know what a toothbrush is, and they have to brush their teeth. And it sounds picky even, but periodontal disease can cause the loss of everything you're doing, and secondary decay is something you're going to be living with your entire life. And you want to have a plan to attack this patient. How do you sequence their treatment? It's critical. When do you do endo? When do you do perio? Which is more important? Are you going to take out teeth and put in implants? Again, these are all decisions that you're going to make and discuss with the patient. Before you start treating the patient, you have to have an idea what the prognosis is going to be. Are they going to be a good candidate? Will they have an excellent prognosis, or a fair prognosis, or a poor prognosis? If it's poor, you even want to begin treatment. And each patient is different. So these are things that you have to keep in that little gray matter between your ears. So you evaluate your patient. You're going to collect data. You're going to collect all the facts about the patient. Okay? The most important thing you will do in treatment planning a case is the preclinical interview. This is the time that you sit down with the patient, as we say, knee to knee and eye to eye, and discuss their medical history, discuss their dental history, discuss their expectations. If you can't meet their expectations, don't pick up a handpiece. If their expectations are out of line with reality, don't pick up the handpiece. I remember having a patient, she came in, she wanted 2 veneers because 60 years ago or something, she was on a soap opera in New York. And she was convinced that if we did 2 good veneers, she'll be back on the soap opera. Okay, you don't want to touch that patient. But this is only an example. But some people are unrealistic in what they want. You have to have a good medical and dental history. What's most important, whatever you hear, you write down. If you don't write it down, it doesn't count. If it's not written down, it is not part of your progress notes. And if you're ever called to task on it, anything not written doesn't occur. Your memory, your recall doesn't even enter into the picture. You do a clinical examination. You look at the teeth, you look at the fillings, you look at the state of the restorations. Radiographic survey. What is a radiographic survey in your practice? My practice, it was 7 vertical bite wings and a Paterex. That's what I needed to start evaluating the case. From there, additional x-rays, periapicals or questionable teeth, perhaps an occlusal loop, perhaps a CBCT. So you have to figure out what your dental needs are of your patient. What's their dental IQ? Do they value their dentition? It has nothing to do with money. okay, has to do with the patient's value system. You can have someone that comes in and they can be able to buy and sell this building, but if they don't value their teeth, all the money in the world will not buy them a healthy dentition. What is the patient's needs and wants? Can you fulfill their desires? If you can't, don't start treatment. So, your clinical examination is very simple. What is their existing disease? What is your chief complaint? Chief complaint is why that patient walks into your office and you write it down in your own words. I want to be able to chew. I want to look better. I don't like this one tooth. What about the restorations, the existing restorations? What are they functional? Are they serviceable? Are they breaking down? Is there decay? Does the patient require an aesthetic improvement? You may have someone come in and we care less what his teeth look like. But if your patient happens to be 18 years old as a model, her aesthetic requirements are going to be much greater than some other patients. And again, I stress the recall and maintenance. That patient has to commit to coming into your practice on a basis, whether it's 3 months, 6 months, once a year. That's for you and your team to decide. Your data review is report all your clinical findings. So you're going to get this information, you're going to gather together, you have what you wrote down for the patient interview, your examination, your radiographs, and accurately mounted diagnostic casts. Diagnostic casts that are sitting on your bench top, now mounted, do very little to aid in your determination of their needs. Diagnostic casts should be mounted on a semi-adjustable articulator with a face bow and a centrically related bite. Do you have to do this for every single patient? Of course not. No. But if someone's coming in and has missing quadrants of dentistry and you're thinking about implants, then the term is absolutely. What is the restorative rationale? Are they candidate for a removable prosthesis or a fixed prosthesis? Sometimes a removable prosthesis will do more than a fixed prosthesis. Someone who's lost their maxillary anterior teeth years ago and has atrophy of the bone and requires lip support is going to need some type of flange. You can't provide that with a fixed case. It should be removable. So the fact that something's removable doesn't mean that it's bad. What is your case prognosis? Again, can you fulfill the needs of this case? And I don't mean the patient's needs. I mean, can you perform the duties? Do you know your work? Do you know your patient? Are you willing to devote the time to learn what to do on your patient? So, let's think about some factors. What is the extent of the decay? How much decay? Where's it going? What about the supporting tooth structure? What about the occlusion? What about the inner arch relationship? And then the aesthetics. When you consider all these, what is the most important? Well, they're all equally important, but one stands out, and that's the occlusion. Because if your occlusion is detrimental to the functionality of your restoration is going to fail. The muscles make up one third of the components that create the posterior dynamic. That is the muscles, the joint, and the teeth. Of those three, one is above and beyond the most powerful, and that's the musculature. Someone who bruxes will destroy anything you can put in your mouth. They will break anything. Remember that on average, your patient will exert 500 pounds per square inch of pressure. And I don't care if it's a 98-pound weakling from the beach. They can chew. Those masters will do a lot of damage. So occlusal factors have to be taken into account. So how do you make a treatment plan? Well, if you look at this slide, you have the results of your patient interview, your patient history, your clinical exam, your radiographic exam, and you have your articulated study models in front of you. Your history may give you some concept of what you're dealing with. There may be medical factors which could influence your case. You have a patient that takes Prolia, a drug to combat osteoporosis. Is this a good candidate to have implants? No, it isn't, because of the incidence of osteoradionecrosis. Without those diagnostic study models, you don't know how to fit your occlusal scheme into this patient. You're going to make up a presentation that you're going to give to your preceptor, and you're going to present it to the patient. You've got to talk to that patient and explain to them what their needs are, what their problems are, and how you're going to help them. Is this important? Well, if you want to eat at night, it is, okay? Because you're the person in practice that's got to drum up the business. And I realize the science part is all important, but when you're in practice and you have your rent to pay, and your spouse wants something, and your car payments, and your kids want a haircut, you got to have the money. And this is why you're going into practice. Your patient has to accept it. Why does the patient accept treatment? Is it because they all of a sudden have this great appreciation for dentistry? No. Anyone want to guess why a patient accepts treatment? They like you. They like you. Probably the most critical factor when you do the new patient interview, clinical history, is you are actually the first step in your consultation and treatment recommendation. Your patient knows whether they're going to like you or not within the first 30 seconds. So you have to kind of sell yourself to that patient. And if you don't, you're going to be always looking for patients. The best referral source you have is your existing patients. If they like you, they will send their friends and family. My late partner used to have a saying, the best patient does 3 things. They follow what you advise, they pay their bill promptly, and they refer their friends and family. That is a good patient, okay? Those are the 3 things you want from a good patient. Are you going to have 100% of those? No, of course not. But you need enough to make your practice exist. Your patient has to accept this. They have to sign off on it. It's very critical, okay? And then you begin. That's when you pick up your handpiece, when everybody knows what's going on. It may take you several appointments to gather all the data. If you have a patient with a badly broken down dentition, you may not be able to achieve everything in one visit. Sometimes it'll take 2 visits. Sometimes your consultation will take 2 visits or 3 visits. Another important thing to remember, who's your patient? Does your patient have someone else that will be assisting in them making the decision? Do they have someone that wants to hear it? Worst thing that can happen is when you have a patient go home and then tells their significant other what you said. We all played that little game when we sat around in a circle, we told the story. What was it, telephone? Okay, by the time we got back, it was a totally different story. You think it isn't true when you tell a patient what is going to happen? And my wife insists on going to the physician with me because I never give her the whole story. She wants to hear it from the horse's mouth. You want your patients and their significant other to hear it from you. Okay? You have to figure out who you're talking to. Types of tooth loss, we have partial tooth loss and complete tooth loss. There's only one answer for complete tooth loss, and that's dentures. Partial tooth loss, we have fixed bridge root, we have removable partial dentures, and we have implant prostheses. With a fixed partial denture, in this case, if you look, we have the tipping of number 18, we have number 19, and we have extrusion of number 3. Okay, number 14 rather, I'm sorry. We know when you look at this, and when you look at this on your study models, that some treatment is going to have to be done to number 14, so you can maintain the occlusal plane. This is a treatment that could be an implant retained restoration or a fixed bridge, either one. But whatever you do, some attention is going to have to be paid to the extruded tooth. When we talk about the edentulous span, we have to discuss how long is the edentulous span? What is the configuration? Are you turning a corner? What about the abutments? Are they aligned together? Are they parallel to one another, or is one tipped? What is their condition? Are they rookie canal treated teeth with post and cores and crowns, which don't make a good abutment? Are they compromised teeth? What is the periodontal condition? Okay. Will they survive having additional load placed on the prosthesis? What is the occlusion? Can you establish an optimal occlusion? The span length is important. Okay? So I have no idea what the one N is, so I won't even attempt to discuss it. But we know this. If we're talking in the posterior, you only want to do a fixed prosthesis in 2 or fewer missing teeth. Today's world, I would say 1. Okay? I can show you x-rays where there were 6, but those treatments go back a long time ago. In the anterior, fewer, 4 or fewer. Okay, I believe implants are the greatest advance to help dental patients. Okay? And you should all be really considering placing implants when you get into practice. Because many teeth we use for abutments may not be suitable to survive 5 or 10 years. Everything in dentistry lasts 5 years. It's after 5 years that the problems develop. There's an old saying about amongst prosthodontists, you should move your practice every 5 years. So what about a fixed prosthesis? So if you have a long span, will it flex? Absolutely. Okay? It will bend. Today we're using very rigid materials. We have metal and we have zirconia. Zirconia is extremely rigid. That also makes it a little susceptible. Zirconia can break. If your zirconia breaks, there's no way to repair it. If your fixed bridge breaks, there's no way to repair it. So what you want to do is take into account all the factors that will create stress or load on that bridge. Number 1 factor, you have to have thick joints where the conics meet the abutments or the retainer. The thicker the joint, the less likely it is to have a fracture. Think of a hanger. You take a hanger and you bend it back and forward with metal. What happens? You generate heat. At one point, it breaks. Same thing happens with a bridge. Same thing happens with an implant. You put a load on the implant and you keep focusing on that load, something's going to give. Hopefully it's just a screw. But I can tell you, I've seen many, many cases where the implant body fractured. That is a failed implant, definitely a failed implant. And that has to be surgically removed. So you're going to use, what type of metal are you going to use? Well, today, you're going to probably use zirconia, but as far as metals go, perhaps something with a little gold in it, you're not using gold, and not precious metal is extremely rigid. But I would think that most of what you'll be doing in the future is going to be CAD/CAM, and it'll be zirconium based at least. And if you look at that bottom, this is what happens when you have a long span and the bridge deflects. And it's no different than driving over the Golden Gate Bridge. And that is, you have to have support to support the middle of the bridge. And if you saw Godzilla, you know why. Span configuration. In the top picture, you have the molar at a 45-degree angle, maybe a 30-degree angle. That is going to be very difficult to restore with a fixed bridge. Can it be done? Yes, absolutely. We used to do it a lot before we had implants. A tiered abutment is the bottom one. That means there's an abutment in the middle of your span. Again, this could be a 5-unit fixed bridge. It also could be 2 implants. So if it's a fixed bridge, that abutment in the middle prevents flexure at the midpoint of your span. If you have multiple missing teeth, you may need additional retention. In other words, if you have the top picture where you're missing 3 missing teeth, I don't think today I would even consider doing a fixed prosthesis. And that's because you have a long span, and when the mandible opens, the ramus in the mandible tilts outward. And what happens in a case like that is you break the cement seal between the tooth and the retainer, and you end up with secondary decay. And does this happen all the time? Yes. Okay, so that's why that case is either a partial denture or an implant prosthesis. As you add abutments, you add retention to the teeth. So you can double abut, which means rather than having 1 tooth, you have 2 teeth. You can make a removable prosthesis. You can make a removable prosthesis that seats on implants. You can make a removable prosthesis that uses precision attachments. The AP axis consideration is, where is the bridge going to rotate around an axis? How far is the interior portion of the bridge from the retentive mechanism? So if you're looking at this bridge, if you have 5 and 6 and 11 and 12 as the abutments, then all the rest of the teeth as pontics, you're going to be rotating around an area just mesial to the cusps. Again, looking at that case, would I make a 8-unit bridge? Well, 40 years ago I did. Today, no. Today that would either be a removable partial denture or an implant case. So you have to look at things in the age in which you're doing them. What about the condition of the abutments? How much decay is there? And what about the periodontal disease? Ideally, the crown-root ratio should be 2 to 3. That means the root should be slightly longer than the clinical portion of the crown. If you have 2 units for the crown, you want 3 units for the root. In picture B, you have a 1-to-1 ratio because you have alveolar bone loss. So that tooth is compromised. Is that an ideal abutment to give you a good prognosis? No, that is a fair abutment, and it'll give you a compromised prognosis. So what type of configuration? If you have a well-rounded root that looks like an inverted ice cream cone, that's not ideal. If you have a big fat root with splayed roots, that is more resistant to occlusal load. Are they aligned in a proper relationship? Or do you have to compensate for tilting or angulation of the abutments. So the periodontal status, we're going to measure the sulcular depth. We're going to look at the attached gingival level. Is there gingival recession? What about furcations? Is there furcation involvement? And are the teeth loose? You have to know every one of these. And this is a time where, as a restorative dentist, you may want to call in a specialist, a periodontist, to assist in this part of the treatment. Why is the tooth loose? Is it due to occlusal load or parafunction, or has there been so much tooth loss that the tooth is no longer stable in the alveolar ridge? The latter, it means you're going to lose a tooth. What about the residual shape and condition? This is important for pontics. It's important for the flanges of your partial denture. It's especially important for your implants. Today, when we see a ridge that is not satisfactory for either a flange of a partial denture or the ridge of a partial denture or implants, then we want to consider bone grafting. Will bone grafting help your patient? Is your patient amenable to having a bone graft? What about the hard tissues, the alveolar? Again, most critical in implants. Do we have enough vertebral height to place a well-sized implant? Again, this can vary from site to site in your patient. And that's why, as a screening tool, the Panurex is a necessity. You can't do this kind of treatment without having a panoramic X-ray. If we look at the occlusal relationships, what is the MICP, maximum intercuspation? That means you're taking the upper member of the articulator, of the cast, the lower member of the cast, holding them in your hands and looking at them. Okay, you might as well look at the wall. It tells you nothing. Okay, it doesn't tell you how this patient is functioning. Centric relation. Centric relation refers to the position of the condyle within the glenoid fossa. It is the hinge axis around which the mandible rotates. This is what you have to know. You have to capture the centric related position. There are many, many ways to do this. We're not doing it today, but if you're mounting a case, it has to be in centric relation. Are you going to do some type of occlusal modification? If you're looking to do a reconstruction on your patient, if you're looking to open up the vertebral, if you need more space somewhere, to try treating this patient without treating in centric relation is a big, big mistake. What is their eccentric? Do they have cuspid guidance? If they have cuspid guidance, are they hitting any posterior teeth? Optimally, when a patient goes into right or left eccentric, they should hit on one tooth, the upper cuspids. No other teeth should touch. They should disarticulate immediately. Do you have to do something to create cuspid guidance? This could be orthodontia. It could be adding a palatal structure to the upper cuspids in order to disarticulate the teeth. Or you have to equilibrate them. What about protrusive? What do we want in protrusive? When the patient goes protrusive, anterior, number one, they should move in a straight line. Number two, the lower incisors engage the upper central incisors, and immediately the posterior teeth disarticulate. Do you have that? Well, you need it. And to verify and compare with mounted clinically acceptable casts. Clinically acceptable means you got everything that you need. You have the teeth. You have 4 to 5 millimeters of tissue reflected in your impression. You don't need, it's not a denture impression. You really don't care about the peripheral folds, but you need 4 to 5 millimeters apical to the pregingival origin. If you look at the bottom picture, that arrow shows a deflecting contact on the lower molar. That means when this occurs, the mandible is being pulled out of centrifugation. This means that the condyle is no longer seated in the glenoid fossa, but more importantly, it means that the lateral pterygoid muscle has to contract to hold the condyle on the articular eminence. Over a period of time, this muscle gets tired. When it gets tired, your patient gets occlusal pain. So, additional clinical factors, oral hygiene. What is your patient's oral hygiene? Do they know which end of the toothbrush goes in your mouth? Caries risk, really, really important. What is the caries risk on your patient? If you have a patient that's drinking 6 cans of Diet Coke a day, they're going to have decay. There's nothing you're going to do to prevent that decay. Acid drinks are the biggest bugaboo you're going to be facing. Are they motivated? In other words, is your hygienist training these people to have good oral hygiene, yet they come in and don't do the job? Are you going to take this case on? That's personal. That's for you to find out. Are they going to come in for their recall? Patients that don't, little problems are solved with little treatment. Just remember that. Systemic health status. Are there factors that will influence your treatment? Osteoarthritis. Panorex, when you take a Panorex or have one taken, you should see both condyles on the Panorex. If you don't, the Panorex has to be retaken. Why is this important? Because there are several different problems that can be diagnosed from looking at the Panorex. Osteoarthritis is one of them. If you look and the condyle is really, really strange, your patient may have osteoarthritis. Dry burning mouth syndrome. Very, very common in women of a certain age. Okay? How much treatment is there for that? Well, some work and some don't. Can you give a simplified treatment? Many times you'll talk to the patient and there's factors which will influence their decision making. I have 3 kids in college, my daughter's getting married next week. That doesn't mean you're not doing a treatment. It means you're going to do a little bit of treatment, but perhaps you're going to delay treatment. It doesn't mean that you say to the patient, well, goodbye, so long, adios. No, this patient, you return him to health, you eliminate disease, but the prosthetic portion of the treatment may be delayed until they have more income that can be spent more freely. And I'll tell you a funny story. I had a senior partner, and he would go through the magazines. Anything that showed expensive cars, vacations, and fancy restaurants were immediately thrown out of our way in. Because he said, if you're going to spend the money, I want it spent here. And so we never had, like, what's that, Architectural Digest. You get it for free, and you immediately come and throw it away. Okay, consider all the information. Now, this is what you're going to be doing. An optimal treatment plan means this is the work I want in my mouth. And that's the way I look at it. This is what I want my dentist to do to me. You can have an alternative treatment plan. This means, okay, we can't do this. You can't have implants. You don't want implants. You don't want to have grafting done. So this is an alternate approach. Right? Number 3, stabilization. I want to do this, I can't do it now. All right, get rid of disease, caries, and periodontal disease. Stabilize the patient, put them on recall. And emergency treatment is just that. I've got a hot tooth, let's get you out of pain, but it's not the comprehensive approach you want to take. When a patient comes in with an emergency, that's pain, swelling, rarely would you see bleeding, but you treat the emergency. So in my practice, they come in with a hot tooth, it'd be a new patient, we would open up the tooth, medicate the pulp canal, and then we would not do the root canal, we would schedule them for a comprehensive exam. Why? Well, I don't know if that tooth is permanently involved, maybe the tooth has to be removed. I know nothing about the tooth, only enough to treat the emergency at hand. You present your treatment to the patient. Again, the patient agrees, they sign the plan, they write the check, and you're off and running. All right, today's simulation clinical. You are going to mount your case. So you have stone models, stone cast. You're going to do a diagnostic wax up. If you remember that from first year. So you want to do a diagnostic wax up. You're going to prepare abutments 28 and 30. These bridge is going to be metal crowns on all 3 teeth. All right? You're going to have a 1 millimeter circumferential chamfer finish line, 1 millimeter, so it's a small ball on your little ball gauge. And you want 1.0 to 1.5 occlusal reduction. All right? It's all you want. The more tooth you lose, the more tooth you sacrifice, the quicker you will institute what you learned this morning. So what you want to do is be conservative. And then faculty evaluation. Lastly, the chamfer must be at least 0.5 millimeter superior to the free gingival line. So you want it 0.5 millimeters above the free gingival margin. And when you take the impression, you want to be 45 millimeters of anatomy captured beyond the type of non-gingival margin. This means you don't need the whole thing, but there should be at least 5 millimeters there. And I'm just reading what Dr. Graves wrote me. To be clinically acceptable, you need a full complement dentition, incisal, occlusal surface is intact, and of course the 4 to 5 millimeters. Anyone have any questions or comments? Yes?
When we do the mounting, are we doing like a Facebook transfer? Or
What are you mounting them on?
how big are we doing it?
Do you have one? Okay. Oh, you got a Stratus? Is there a mounting? I don't know how you write it. Can you take a Facebook on these mannequins? You might as well, because I don't know how else you're going to mount the upper member. So you better take a Facebook. Okay, so mounted on a Stratus, you're going to use maximum intercuspation here, okay? So you're going to articulate the upper and lower.
What type of wax do you use for the wax up?
You still have your inlay on dental and wax? I would use that. Yeah. You're going to wax up the teeth. You have an edentulous area at 29 and 30. You're going to wax up 3 teeth. You're going to wax up 29, 30, and 31. Okay? Okay. You have, let me have your attention, please. This is an important question. You have an edentulous area at 29, 30, 31, right? Okay. Just what about 30, 31?
Those are
Okay, all right, you're good. Then I would say you prepared dirty already. So you're going to wax up the pontic in 29, or 20. You're going to wax up a pontic in 29, 28 you haven't prepared yet. Okay, 29 you're missing, and 30 is prepped. So I would say you're going to wax up 29 and 30. Okay? Well, you need waxing, if you're going to use integrity, you have to have a form to use the integrity.
We just need to wax up 29 for this project.
Because she said, waxing of the edentulous areas. So I assume you're supposed to wax up 29. I would say 29. If you have if you've already taken the impression. So wax at 29.